So now that we have the autonomic effects down on the heart, we can look at the effects on the rest of the body. Now I'm going to warn you, there's going to be a lot thrown at you in this section. This is incredibly high yield, and I would really spend your time reviewing these lecture slides afterward. So here on the left, we're going to look at the parasympathetic nervous system, and on the right, we're going to look at the sympathetic nervous system. And the first thing to note here is remember that the parasympathetic nervous system is also called the craniosacral because it's coming from the cranial nerves 3, 7, 9, and 10, and also from the sacral nerves S2 through S4. Let's just quickly point out what these cranial nerves are doing. Cranial nerve 3 is constricting the pupils. Cranial nerves 7 and 9, those are responsible for most of your kind of saliva and secretions in your head and neck. Cranial nerve 10 here we know is slowing the heartbeat. We covered that in the last lecture. And essentially everything here from kind of the voice box down is part of cranial nerve 10, the vagus nerve. And then down here, like we said, we have the sacral S2 through S4. Now in between those two, we have the thoracic and the lumbar nerves. And so this is where the sympathetic outflow comes, thoracolumbar. It's all of the thoracic nerves, T1 through T12, and then all 5 of the lumbar nerves, L1 through L5. Now, when we deal with autonomic pharmacology, the reason we need to kind of understand the systemic effects at all of these multiple different organ systems is because one neurotransmitter can have multiple effects. Acetylcholine can affect the heart, the lungs, the stomach acid, and the intestines, and the bladder. So if a patient comes in with side effects, you should be able to review their medications and see, well, which one might be causing this. So the way that I like to remember some of this is with using some imagery. And so for the sympathetic nervous system, the imagery that I like to use is imagine you're in the jungle and you're running away from a beast at night. So it's nighttime and you need to be able to see. So the first thing you need to do is dilate your pupils. Dilating your pupils lets more light in, you can see. The second thing you're going to need to do, and this is just my way of remembering it, and it might help you as well, is that you need to get oxygen and sugar to your vital organs. And if you remembered anything from biochemistry, you should remember that the most efficient way to make ATP is to take oxygen and a byproduct of sugar, and that makes ATP very efficiently. And so with this in mind, we come over to our diagram here. If we're going to need to get oxygen into our blood, we want to relax the airways. That's what we see here. And if we need to get sugar into our blood, well, that happens at the liver down here, and sympathetic activity stimulates the release of glucose. So those are the two important points. And remember, if we're getting this oxygen and this glucose into our blood, we need to push it to our muscles. And so we're going to increase the heartbeat, and we saw that in the last lecture at the SA node. And finally, this is more of a silly point, but it has clinical relevance, and that is when you're running away from some sort of beast, you don't have time to pee or to poo or, for that matter, have a baby. So the sympathetic branch of the nervous system, this is going to relax your bladder. But the clinical relevance here, and in terms of how we use this in pharmacology, is regarding the tightening of the sphincter. So relaxing your bladder and tightening of your sphincter is a sympathetic approach. Now, pretty much the opposite of all of this is true with parasympathetic innervation. And there's a couple of points that I'm highlighting here, and these are the ones that are high yield. So the imagery you can use here is imagine that you're reading a book while sitting on the toilet in the sun. So the first part here is that you're reading a book and you're in the sun. So you're in the sun, you're constricting your pupils, and you're reading a book. You're looking at something in front of you. This is accommodation. Both of those are using acetylcholine. The constriction of your pupils is what's specific to the parasympathetic nervous system. But remember, with accommodation, you have those ciliary muscles kind of tugging on your lens to bend it to look at things up close. Those muscles respond to acetylcholine and have muscarinic receptors. We'll get to all that here in a second. The second point here is you've got nothing to do. You're, sitting on the can. So your heart rate's going to be slow. You don't need to have dilated airways, the exact opposite of the sympathetic portion. And finally here, you are on the toilet. So the point I'm trying to make here is that, it would be nice to have increased GI and GU activity. And the places we see that is that we increase activity on the stomach. Remember that the vagal nerve is kind of causing an increase in stomach acid secretion. It also leads to increased GI motility and thus can lead to diarrhea if we overactivate it. The big one here is contracting the bladder. So it's going to do exactly the opposite of what the sympathetic do. Sympathetic relax the bladder. This would contract the bladder, and this would also relax the sphincter. So these are kind of important points to have in mind. Now, before we get to the next slide, I kind of want to point out something that might seem like a contradiction, but it'll help us understand what's happening. So here's a question of how does something make sense? So sympathetic output leads to a decrease in blood flow to the skin and intestines, but at the same time increases blood flow to the skeletal muscles. How does this make sense? And so the answer to this question kind of lies with this adrenal medulla, which is secreting epinephrine and norepinephrine. And the point here is, with one neurotransmitter, you can have multiple effects because there are different receptors. And autonomic pharmacology, especially with the sympathetic side of it, we are kind of differentiating between those receptors. And so epinephrine and norepinephrine, when they are released, they can both bind to that alpha-1 receptor, and those are found on the smooth muscle of the vasculature leading to the intestines and to the skin. Whereas on the skeletal muscles, we have these beta-2 receptors. And remember that epinephrine can bind to these beta-2 receptors with relatively high affinity, but norepinephrine does not. So by binding to the beta-2 receptors that on the vasculature leading to the skeletal muscles, we can get blood flow there and kind of keep blood flow from going to the intestines and skin. So that's a good rule of thumb, that alpha-1 contracts and beta-2 relaxes. And that's the point of this next slide. We have multiple receptors, and we're just going to cover 3 of them right now. We're going to ignore alpha-2. But for now, I want you to remember here that alpha-1, if you think about what it does, think that it contracts. Beta-2, I want you to think that it relaxes. And beta-1, we covered in the last lecture, really focuses on the heart. So we're back to our example here. We're running away from this beast at night. So point number 1, we need to see how is it that an alpha-1 receptor, which causes contraction, will dilate the pupils. Alpha-1 dilates pupils. Let's look at this diagram here on the right. So remember that the pupil has 2 muscles. It has a dilator muscle, which is a radial muscle going outward, kind of in all directions. And it also has a sphincter muscle, or a circular muscle, surrounding it. If I contract these radial muscles, which happen to have alpha receptors, what happens is that they kind of, when they contract, they're pulling in both directions. And that's going to lead to the pupil getting larger. On the flip side, the circular muscle has muscarinic receptors, and when that contracts, it gets smaller. But we'll get to that here shortly. So this does not violate our rule. Alpha-1 is contracting these radial muscles, or these pupillary dilator muscles in the eye. Number 2, we need to get oxygen and sugar to vital organs. So we saw with beta-2, one of the places it works at is the lungs to increase the amount of oxygen. And so we are relaxing the airways, we are relaxing the smooth muscle in the lungs. And so we're going to hit some high yield board topics here. This is a great pharmacologic approach towards treating asthma. We give them a beta-2 agonist, and that is going to help relax their lungs for these asthmatics who have, hypersensitivity or kind of constricted airways. The other thing that beta-2 does that we talked about was that it stimulates the release of glucose. Now remember here, we stimulate the release of glucose. This also, actually, I want to make a point here. When we release glucose, we increase insulin. And so beta-2 receptors you should think of as increasing the amount of glucose with a glucose-induced insulin release afterward. But the clinical points here that they're going to test you on is with not somebody who's taking a beta-2 agonist, they might, but with a diabetic who's taking an antagonist to beta-1 and beta-2 receptors. We call those non-selective beta blockers. Non-selective in that they're working at the beta-1 and the beta-2 receptor. And so we need to be cautious when we use these beta blockers in diabetic patients. So a diabetic patient is going to invariably have some sort of problems with his heart at some point, or most of them end up having problems. So we might want them on a beta-1 blocker to decrease their heartbeat. But there are beta blockers out there that work on both beta-1 and beta-2 at the same time, and that can be problematic, and we need to use those cautiously. Well, why? Well, one, if we use a beta-2 blocker, this might lead to a constriction of the airways. Remember, beta-2 normally relaxes, so if they are blocking beta-1 and beta-2, this would block their airway. Two, if this beta-2 is what is causing the increased release of glucose, that might lead to hypoglycemia. And three, when a patient is hypoglycemic, they have a sympathetic response. Their body releases epinephrine and norepinephrine, and the goal here is with the epinephrine to increase the amount of glucose released at the liver. But also what happens as a result is it's going to increase the heart rate. It's going to make them kind of jittery and sympathetically anxious. I don't know if that's really a word, but have a sympathetic response that kind of precipitates as anxiety. But these beta blockers are going to block some of those signs that might tell them that their blood sugar is too low. So it masks the signs and symptoms of hypoglycemia. And finally here, we get to point number 3. And that is, you don't want to pee or poo or have a baby. And so as we said here, the beta-2 receptors, they relax the bladder. That follows our rule. And what the alpha-1 receptors are doing, these are constricting the sphincters. And this is the important one. I should have highlighted it. So let's look at, this guy right here. So here's our friendly gentleman, and we are zoomed in on his bladder. And the treatment, what we're showing here is that this is a prostate. Here's the bladder wall. This guy has benign prostatic hyperplasia, BPH, a incredibly common problem in older males. And so, as we said, alpha-1 contracts. The alpha-1 is contracting this kind of sphincter to the bladder. This is the prostatic smooth muscle. So, boom, a treatment for people who have BPH is to use an alpha-1 blocker, an alpha-1 antagonist, and that would help relax this bladder, prostatic smooth muscle sphincter. And finally, like we mentioned, if the beta-2 receptor relaxes the uterine walls, we don't want to have a baby. So if a woman is going into preterm labor and we want to avoid or delay her pregnancy, we can give her a beta-2 agonist to help postpone it. So high yield, high yield, high yield. Let's move over to the parasympathetic side. So an important point to make here is that cholinergic drugs are not very specific for receptors. As we kind of showed you on the last slide, with the adrenergic stuff, we have stuff specific for the alpha-1 receptor, for the beta-1 receptor, for the beta-2 receptor. Here, most of these drugs are working on multiple receptors. So just something to keep in mind. And what that means is that there's going to be a lot of side effects unless we give a drug locally. So for these airways, unless we give an inhaler, we're going to see systemic side effects. So in terms of these receptors, I'm just going to briefly touch on this. The receptors are relatively easy to learn. The M1 receptor in the CNS. The M2 receptor we already learned is at the heart. And pretty much the rest is M3. So M1 in the CNS, M2 at the heart, M3 everywhere else. Some people like to say M3 makes you pee. That's an easy way to remember it. So let's kind of go through some of these, kind of similar to what we did before. So at the level of the eye, it's that M3 receptor that is contracting the circular muscle of the pupils. The radial muscle we saw was the alpha receptor. This circular muscle is working here, and this is a muscarinic M3 receptor, which responds obviously to acetylcholine. So we're going to kind of work our way down the list here. Remember that saliva and all secretions are acetylcholine and muscarinic receptors. But an important one right here is the slowing of the heartbeat. We covered that in our previous lecture. Increased vagal tone on the SA node increases the heartbeat or the heart rate. But what we did not cover was how it does this. And so you've learned this before in physiology, the baroreceptor reflex. And this is a huge place on the boards. They love to ask questions because it shows the interaction of pharmacology with physiology. And so briefly, the way this reflex works is we have receptors in the carotid sinus and in the aortic arch. The receptors in the carotid sinus, remember, are from cranial nerve 9, the glossopharyngeal. The receptors in the aortic arch are from cranial nerve 10. And so when those guys get stretched, let's say there's a rapid increase in blood flow, those are going to increase in firing. And that ends up going to the brain, and eventually it works its way back to the efferent part of the vagal nerve, and that increases the vagal tone on the heart. It decreases the heart rate. So if it gets stretched, we have an increase in firing. If, and this is where you're more likely to get tested, if you have a rapid decrease in blood pressure or a decrease in systemic venous return, that's going to cause a decrease in firing, and that will result in a decrease in vagal tone or an increase in the heart rate. And at the same time that it's working through the parasympathetic side, it's doing the exact opposite on the sympathetic side. High yield board topic. The next part here is constricting the airways. So some patients with asthma have a hypersensitivity to an acetylcholine agonist. This is a great way to help diagnose asthma patients, especially with children. So we call it the hypersensitivity test. We have them inhale an acetylcholine agonist. If they start wheezing and have changes in their respiratory function, that might show they have asthma. On the flip side, instead of using an agonist, we can use an antagonist to do the exact opposite and help treat their asthma. So a patient who has asthma or COPD, we can give anticholinergics to open their airways and to decrease secretions. Again, I'm throwing a lot of high yield points here at you. You need to review this later if it's coming at you too quick. In terms of the stomach activity, remember that acetylcholine acts on those parietal cells to increase stomach acid, but that's not the major route in which it increases stomach acid. The major way it did it, remember that acetylcholine would bind to those enterochromaffin-like cells, and that would cause an increased release of histamine, which really cause an increase in stomach acid. And so we can see here how autonomics might play a role in peptic ulcer disease. Coming back down here to the intestines, GI activity, increased motility. So one potential place you might see this is a patient who takes a drug or a toxin that causes a large increase in parasympathetic activity. What might happen? Well, you would see that it causes diarrhea. And how would you differentiate this diarrhea from, let's say, food poisoning? Well, you would see diarrhea, but you would also see a decrease in the heartbeat. You would see lots of secretions and constricted pupils. So this goes together, and that's why you need to understand the system as a whole. Finally here, coming back down to the bladder, acetylcholine or parasympathetic activity will cause contraction of the bladder and will relax the sphincter. So for a patient who has an atonic bladder or a floppy bladder that doesn't squeeze very well, we might want to give them acetylcholine. Or if they are a post-op patient and their bladder is not working very well, we can give them this acetylcholine type agonist to help squeeze their bladder and relax the sphincter. But this is not what we would want to use in a patient who has a mechanical obstruction like BPH. Here, remember, their sphincter is closed tight and their bladder is already very thick and strong because there's a lot more resistance. So for here, we don't want to contract the bladder for them. That's not the solution to our problem. The problem lies with the sphincter. So note that difference. And finally, if an agonist can help you urinate, an antagonist or an anticholinergic can lead to urinary retention. And there are loads and loads of drugs that have anticholinergic-like effects. Whenever you see that, you should make associations to what we've talked about here. So we've just covered a lot of information. And I just kind of want to point you to two references in first aid that we've essentially gone through. On the 2012 version, page 263, here is kind of a list of all of the G protein linked second messengers, but all of the receptors, the alpha 1, alpha 2, beta 1, and beta 2, and the 3 muscarinic. It gives you the G protein class, and then it goes through these major functions. And that's essentially what we've done in this lecture. Now, we didn't cover the G proteins in detail, but there's a little mnemonic here to help you remember it. So in this order, alpha 1, alpha 2, beta 1, beta 2, M1, M2, M3, the 2 dopamines, histamine, and vasopressin. It's kiss and kick till you're sick of sex. So this is written down here. I highly recommend coming back to this and kind of learning what the receptors are, the G proteins, and the major functions. Hopefully this will make sense to you because of this lecture. And secondarily, they have a nice page where they go over what the G proteins are and what these second messengers are. In particular, that the GQ receptor, activated phospholipase C, which act at the cell membrane to, break up these lipids and increase the levels of diacylglycerol and inositol triphosphate, and little here things to help you remember it. So, a lot of clinical stuff that we've thrown at you. I've produced a little list of kind of a lot of these important points that you should be able to answer that are related to autonomic pharmacology. So you won't know the answer to all of these now, but when you're done with autonomics, kind of come back to this list and make sure you can answer or you understand how autonomic pharmacology kind of relates with all of this.